This World Shared Practice Forum will differ from our typical World Shared Practice Forums. This video is an installment of our History of Medicine series, in which we will be discussing the history of modern medicine with experts from around the globe. Unlike most World Shared Practice Forums, there will be no discussion questions during this video. However, if you would like to ask a question or leave a comment, please feel free to do so at any time. Thank you, and we hope you enjoy this video. Welcome to World Shared Practices Forum. I'm Dr. Jeff Burns, Chief of Critical Care at Boston Children's Hospital and Harvard Medical School. We're very pleased to have with us today Dr. Christopher Newth. Dr. Newth is Professor of Pediatrics at the University of Southern California and attending physician at Children's Hospital, Los Angeles. Kit, welcome.
Thank you very much for having me, Jeff.
Kit, around the United States, around the world, you're known for the research that you've done in pediatric mechanical ventilation for the last 3 decades and more. And we're pleased to have you with us today to hear your view of where we've been, where we are, and where we're going. Kit, could I ask you now to kind of look back? Where has the field of mechanical ventilation in general, but pediatric mechanical ventilation come from? What are the important milestones that we've reached?
Well, I think it's hard to separate out pediatric mechanical ventilation from overall mechanical ventilation for the start, from the start. But I think we've really come from the time of the old negative pressure ventilation, which was really the start of it. Various methods of resuscitation were attempted during around about the middle 1700s, and then after that, the positive pressure bellows were used largely, but it was discovered after a while of experimentation that this could lead to a pneumothorax. So the French Academy and the Royal Humane Society, in their wisdom, then banned this sort of research, which of course is almost the history of medicine. That puts a stop to things for a while, and then it inches forward. Concurrent with that, there was really advances made in intubation, and if you go back to first endotracheal tube being invented in about 1788, through to the first laryngoscope being invented in 1895, really we've discovered most of the major tools of intubating during the course of that time before the turn of the 20th century. Of particular interest during that time was I think for pediatrics was the O'Dwyer endotracheal tubes, because they were really developed by O'Dwyer for use in diphtheria, which of course was a fatal, almost universally fatal pediatric disease. And those were the silver tubes that could be put in through the mouth and down through the membrane for a while and then taken out. That was really quite an advance in pediatrics. If we switch at that point to go back to thinking of ventilators, the first real attempts at ventilators were negative pressure ventilators. And I believe the first one was invented by Jones in Kentucky in the middle 1800s. And there's been an evolution of them with various people's names. Perhaps the one that's most relevant to Boston, since that's where we are at the moment, was the Drinker, or the Drinker Shaw iron lung, which was developed, I think, in about 1928 and was first used ever on a patient at Boston Children's Hospital, I believe an 8-year-old, and who did well. Then that also evolved into the Emerson ventilator, also came from here, and that was the one that was most widely used, certainly around North America. And there are always the classic pictures of the Los Angeles County Hospital with the banks of iron lungs and the polio epidemic, showing the nurses standing beside them and a patient in each one receiving what was their life support at that particular time. Mm-hmm. Positive pressure ventilation really started a little bit later, but with it there was an appreciation of some of the physiology, things such as the Herring and Breuer reflexes involving the vagal nerve. They used a lot of bellows, but started to get a lot of experience with positive pressure ventilation, Meltzer's intratracheal insufflation technique, which was a double bellows sort of blowpipe arrangement. But again, with the advances, people got nervous, and because they found there were pneumothoraces or problems, it was declared as unuseful for certain types of surgery to use positive pressure ventilation. Again, slowed things up a little bit around about the 1900s. The polio epidemic, which obviously promoted the use of negative pressure ventilation, also spurred eventually the development of positive pressure ventilation, and a lot of companies got into it, even companies which we would never think of being associated with ventilators, like Bang & Olufsen, noted for their audio equipment and so on, actually made ventilators to support people in that epidemic, and some of which I'm told from the people in the Bang & Olufsen Museum, they still exist to this day and they still work. So we had an explosion of technology around about this time, and explosion of technology both in the making of ventilators, but also in the interfaces between ventilators and the people that they served, but also some of the equipment for handling sick children and adults, of course. Needless to say, very strong opinions got formed on various things. If you have a successful approach to something, there's a great tendency not to want to change it. So anybody who does attempt to change it in the form of an improvement or otherwise strikes a lot of resistance. So we have many sacred cows that have been that have occurred. They've been created, and however, the good thing about sacred cows, as Mark Twain famously said, they make wonderful hamburgers. So some of our job nowadays is to make hamburgers.
So Kit, that was a wonderful overview of the history of endotracheal tubes, laryngoscopes, and early forms of assisted ventilation. But I'm sure our colleagues around the world are very interested to hear your views of where we are now. And in particular, can we begin with the endotracheal tube? As you noted, it was the first thing that was kind of discovered in the era of assisted ventilation. Can you tell us the story of cuffed tubes, uncuffed tubes? Where are we today?
Well, I think as with ventilators, we've come a long way. But as with all these things, there have been battles on the way. Some of the endotracheal tubes that were used were made of materials which caused damage to the human trachea. So it really wasn't until we got to some of the synthetic materials and got away from the rubber type materials that we got good endotracheal tubes. The first ones were, of course, uncuffed, and it was felt from the anatomy that uncuffed tubes were the only things that should be used in a narrow, through the narrow subglottic region of the child's airway. I think this was a view which was very strongly held by some of our ENT colleagues, and there was a great deal of resistance to using even uncuffed tubes in things like epiglottitis and croup. In the mid-1960s, a couple of Australian anaesthetists actually really showed that uncuffed tubes could be used safely under those circumstances, but those battles lasted into the 70s and in some institutions even into the 80s. Well, the next tube the next advance that was made was with a cuffed endotracheal tube, but the cuffs were made in such a way that they were relatively low volume and therefore relatively high pressures could be created in them. And so these weren't altogether the best tubes that we could have, and again gained a little bit of notoriety in certain areas. The next advance, I believe, was really the cuff volumes were changed so they became high volume and low pressure, so these could much more be safely used. But I think we and others have published our data showing that really, provided you pick the right sized tube to start with, be it cuffed or uncuffed, they're equally safe to use. The cuffed tube, in my opinion, has certain advantages because, particularly in the middle of the night, you're not asking somebody to have to change a tube because it's suddenly got a big leak or because people think it doesn't have a leak at all and should have. So I think that has been a major advantage in the advent of these particular tubes. The tube sizes have been standardized in the sense of internal diameter. So as you well know, you can get a tube from 2.5 and a half sizes internal diameter in millimeters up to 9. So, but of interest is that the outside diameters have never been standardized. So if you have several different endotracheal tubes side by side, you'll see that they will all have slightly different outside diameters, which clearly is important if you're putting it inside another tube, the trachea. The other thing that hasn't been standardized is the placement of the balloon. And some of the cuffs on the tubes are actually quite proximal. And once you've placed one, you can look in and see that you actually see the top of the balloon through the vocal cords, sometimes even into the oropharynx. So I think that the better tubes that are being made with the cuffs rather more distal. And another advance, whether it's an important advance or not, I don't know, but is also the ridged cuff, where there are longitudinal ridges in the cuff, which allows different pressure points and perhaps the drainage of secretions through those. And people like Marcus Weiss in Zurich have looked at these sorts of tubes quite strictly, but I don't know if they're really a major advance or not. They're nice tubes. From that point, of course, endotracheal tubes, particularly small ones, are also associated with some of the sacred cows that I mentioned before. The biggest one being, of course, is that for an infant, if you put in a small tube, it's like breathing through a straw. And it surprises me that people who have otherwise excellent observational powers cannot see that a child breathing on CPAP through a small tube is doing just fine, thank you. And the reason is very clear. If you look back, even at work from the 1970s and 80s, there's some very nice presentations. If you think of the cross-sectional diameter of the trachea in a newborn baby or a small baby who would have a size 3 internal diameter tube in place, perhaps, the surface area or the cross-sectional area, sorry, of the trachea would be about 7 millimeters squared. If you go to an adult, you might be having a 9 tube, 3 times larger than the adult, but now the surface area of the trachea is 10 times greater. So in actual fact, the relative size of the endotracheal tube that you put confidently into an adult is much smaller relative to their body size than it is in an infant. So who's really breathing through the straw? Of course, it's the adult. When one interprets issues such as resistance to airflow through tubes, it goes without saying that if you take a small tube and you push pressure through it or you put airflow through it at higher and higher flows, that the resistance will go up, at least to a certain point. And there are a number of studies which demonstrate this very clearly, but they show that if you have a big tube, like a 6 millimeter ID tube, then airways resistance will remain very low, even at quite high flows. Whereas if you put those same flows through a small tube, a 2.5 or a 3 millimeter ID, of course the resistance will go up. And that is then taken as proof that it's breathing through a straw. Well, of course, it's irrelevant because it really is at what flow rates the infant or the adult is breathing that tells you whether its resistance is going to be a limiting factor. Max Klein showed some years ago that peak and mid flows in normal human beings anyway is about half a litre per kilo per minute. So if you think about that, somebody who's breathing through a 6 millimeter internal diameter tube will have a flow of, if you put a flow through of 30 litres per minute, that'll be a low resistance, it'll be about 20. If you are going to extrapolate that back to a baby with a 3 millimeter tube, if you put 30 litres per minute through that tube, the resistance would be off the roof. But say that child was 5 kilos, then really he would be breathing at 2.5 litres per minute. That would be his peak flow. And if you plot that out, that resistance is going to be very low. So there is no added resistance really to a small tube in a small baby because they're breathing at much lower flow rates.
So Kit, that's a wonderful overview, and as you noted, many of the sacred cows that I was raised on, you just debunked. But I wonder if I could ask you, because I'm sure our colleagues around the world are wondering, what do you do in your actual practice? So could I ask you, what percentage of your patients are cuffed endotracheal tubes, and what percentage of your patients are uncuffed endotracheal tubes? And could I also ask, do you prefer orally or nasally intubated patients?
Well, I think in terms of the first one, cuffed versus uncuffed, I would say that in our ICU, most of the patients who arrive in an emergency will end up with a cuffed endotracheal tube. Now, we have a lot of post-operative patients who are going to be very short-term, and they will come back from the operating room without a cuffed tube, and I certainly wouldn't change that to a cuffed tube just for the sake of doing it. But anybody with emergency stuff, particularly if it looks as though it's going to be respiratory in nature, you may end up with stiff lungs or bad airways and so on, we will have cuffed tubes in them. In terms of nasal versus oral, I was taught always to nasally intubate. I'm probably a bit of a dinosaur. I teach the fellows how to nasally intubate so that people can do it. Certainly helpful at times when children have facial trauma or other deformities to be able to put a nasal tube in, but the majority of our children are orally intubated. I've always had a belief that nasal tubes stayed in position better. You had less unplanned extubations with nasal tubes. And I think there is some evidence coming out in the near future which will suggest that that is true.
Kit, I wonder if we could move now into the present era, and in particular, what's the evolution of mechanical ventilation that we should know about and understand?
Well, I think from my perspective, of course, it's always swayed by what you were exposed to when you were young, but I think the first ventilator that I remember so well was the old bird ventilators invented by a man who didn't trust electricity, so they all ran off air and oxygen. And they were difficult to use, but believe me, if you could actually deliver racemic epinephrine through a face mask using one of those bird ventilators, you knew how to run a ventilator. I think there were no screens in those days, nothing much else except a gauge to tell you what you were doing. A pressure gauge to tell you what you were doing. We moved then into the age of having this explosion of different modes of ventilation, all of which will have their acolytes, of course, that for certain specific diseases, these are the only ways to ventilate. Again, still no graphics. Example of that would be the Servo 300 ventilator. And then more recently, where computer technology has clearly been more incorporated, and we have wonderful screens now with interfaces that can show graphics, they can show nice little cartoons of lungs going in and out, they can do calculations for you, most of which are not necessarily very appropriate to pediatrics, but some ventilators do have some pediatric work in them.
So Kit, when you walk into a room, what information are you looking for from the ventilator?
There are numbers of different things that I will go to fairly automatically, depending upon which ventilator I'm looking at. Clearly the flow traces of pressure and volume and flow are helpful. They may give you information just in the linear plot of whether you've got air trapping, whether you're actually getting back to baseline on your flows and things like that. One could look at calculations of resistance and compliance, or tidal volumes, mils per kilo, predicted body weight or ideal body weight, and things like that. But I think we've also had to learn that you have to have some caution interpreting some of these graphics. And a good example of this is the good old flow volume loop. The shape of the flow volume loop may depend very much on where you actually record the flow and the volume from. And there can be vast differences between if you are measuring it back in the ventilator as opposed to measuring it on the proximal end of the endotracheal tube. You can have a 3 times difference in tidal volume per kilo, depending on, in a small baby, if you're actually ventilating them, measuring it back in the ventilator. You may make some mistakes doing that. The other thing is that the graphics can be misleading, particularly with small kids with big ventilators and compliant tubing. Some of the flow volume loops may look as though they're quite obstructed, even in tidal breathing. Whereas if you measure it on the proximal tip of the endotracheal tube, you'll find that in fact the flows look perfectly normal and there's no evidence of any airflow obstruction whatsoever. So one can make misinterpretations if one is not careful.
In your practice in Los Angeles, do you put what we call a pneumotac or a flow sensor on the proximal airway in every patient, or in some patients do you rely on the sensor built into the ventilator more distally from the patient?
Yeah, on many patients we will rely, be cautious, but we will rely on whatever number comes out of the ventilator because many patients have normal lungs, particularly post-operative ones and so on. There's no particular need to be worried about that. But if somebody has pulmonary disease or cardiopulmonary disease, then yes, we will monitor them on the endotracheal tube. Now, we may not necessarily monitor them continuously because sometimes there can be trouble with secretions and things like that, but we will monitor them regularly and check their tidal volumes and so on that way.
Do you worry that the extra weight of the pneumotac on the proximal airway leads to unplanned extubations more commonly than it should?
If that was my only worry about unplanned extubations, I'd be happy. But no, these pneumatacs are now very, very light. Some are combined with end-tidal CO2 sensors. They're a little bit heavier, and of course, but I think that's just a matter of good care in the ICU. One can overcome these problems fairly easily. I mean, the weight of the old end-tidal CO2 sensors back in the late 1980s, they were pretty heavy, and compared with that now, these are very light. So, again, advances in technology have given us benefits.
So, Dr. Newth, around the world, one of the most common and often difficult disorders for our colleagues to manage is an infant or a child with bronchiolitis. Could you talk to us about the evidence in your experience in caring for a child with bronchiolitis? What are some of the issues that we confront?
Well, I think some of the issues that are one of the major issues perhaps that one has to confront is that not all RSV infection is bronchiolitis. That seems to be those words seem to be commonly put together, but in fact RSV can just as easily cause respiratory failure through pneumonia progressing to ARDS, and that actually is the group that you get the deaths in, the infrequent deaths, as opposed to the kids with RSV-induced respiratory failure from bronchiolitis. The differences are often clear radiologically. The sort of non-homogeneous patchy changes throughout the X-ray of a child with pneumonia or ARDS. But we've been able to apply things such as pulmonary function tests, not always straight out of the ventilator, but been able to apply pulmonary function testing to these diseases to tell us where we might be in their severity and in their evolution. It's fairly simple in a straightforward case to show that a passive deflation flow volume curve, for example, often done under neuromuscular blockade with an intubated child, obviously, will show you a very rapid time constant of the respiratory system. And if you do a forced deflation, a fairly normal-looking exhaled flow pattern, but a small tidal volume. That's classic for pneumonia or ARDS. Whereas if you were looking at bronchiolitis, histologically you'd see that the bronchi are loaded, unlike at ARDS where they don't have much stuff in the airways at all. So in bronchiolitis you've got lots of detritus and cells and one thing or another sitting in the airway, sort of a hyperinflated pattern, maybe with a bit of patchy atelectasis on the chest X-ray. But if you look at the pulmonary function tests, you'll see not only the same low tidal volume that you have, vital capacity breath, on a forced deflation, but you'll see that it's very obstructive in its expiratory flow. And also the passive deflation will show a very long time constant. So when you look at those two, it's fairly easy to separate them, and you'll use very different ventilatory strategies on each case, depending on whether you think they have interstitial disease as in ARDS or airway disease as in bronchiolitis. The pulmonary function tests that we can do now are actually quite sophisticated on mechanically ventilated children. We were able to develop a number of these on monkeys, the non-human primate if you like, and then bring them back to working on the human primate. But we can do a battery of pulmonary function tests at the bedside now, which are pretty much as the same as you can do in a stand-up, walk-in, older children's or adult pulmonary function lab, so we can get residual volume or total lung capacity and all these other things if needed for any particular studies or try to sort out some pathophysiology. we've been able to use these sort of results for risk stratification and severity of illness and so on and so forth. I think one of the other pulmonary function tests, if you will, which has been of particular interest to me, but I think will be of value going forward, and certainly has been to a degree in the adult world with Tobin and people like that looking at it, has been the pressure rate product, or one of those variations on a theme where you're looking at peak to trough esophageal pressure and the rate at which somebody breathes, all of which you can get off an esophageal pressure probe, for example. The pressure rate product is the peak to trough esophageal pressure multiplied by the respiratory rate, and it's fairly easy to record directly off an esophageal pressure probe because you see the deflections and you can also tell the rate against the time base. It's a very good surrogate for the work of breathing as it was first described, but really should be more accurately called the effort of breathing. So continuously you can see how much effort it's taking somebody to take a tidal breath. This can be used in anybody who is spontaneously breathing, and it is actually, it can be used in anybody with any disease, but certainly in the scenario of lower airway obstruction, be it asthma or bronchiolitis, or even an upper airway obstruction, but you can actually look at these traces and see what their pressure rate product is and if anything you can do to make it change. In lower airway obstruction, of course, these patients all have some degree of Autopeep or intrinsic PEEP, and by dialing up and down the PEEP, you can actually change the amount of effort it takes them to take a breath in.
So could we talk about that? This is one of the most commonly asked questions among physicians in training, which is in the setting of hyperinflation and the concern for Autopeep, how do you determine when to add applied PEEP and when not?
Well, let me take the circumstance of when to apply. I think that is, at least in my view and in my practice, the time for that is when patients are spontaneously breathing, still intubated, fine, but they are spontaneously breathing and you're weaning them down, for example, from an asthmatic episode. I think the important point about that is that if you increase the PEEP up too close to what their Autopeep would be, is that you then minimize the amount of effort they have to get to trigger the ventilator to give them the pressure support breath. So for any patient with obstructed airways, lower airway obstruction, if you really want them to have the benefit of pressure support, if you believe in pressure support, the best thing to do is to actually adjust their PEEP so that it's easy for them to trigger the breath. So concentrate on the PEEP first, and the pressure support will come along with that afterwards. We've shown that, and others have shown that as well. When not to use PEEP? Well, I think when you're fully ventilating somebody with severe lower airways obstruction, that is not a good time to use PEEP. They have plenty of PEEP. You're doing the work for them. They're not initiating a breath. And I think as David Tuxon from Adelaide showed years ago in some adults, you can actually get patients into quite a lot of trouble by going up too much on the rate or too much on the PEEP when you're fully controlling their ventilation. That's when you get into trouble with air leak syndromes and cardiac tamponade and so on.
So in a patient who's neuromuscularly blocked and paralyzed, no indication for applied PEEP in the setting of Autopeep, but in a patient who's breathing spontaneously on assisted ventilation, whether flow triggered or pressure triggered, there you would add applied PEEP so that the patient is able to trigger the breath comfortably with every effort to avert the kind of imposed inspiratory threshold load. And to make their work of breathing less.
Yes. I mean, I happen to use pressure rate product, and that's easy for us to do in our institution, but really you can do this at the bedside clinically, just looking at the patient. You turn up the PEEP on a spontaneously breathing patient, and you will reach a point where it's obviously less effort for them to breathe. One of the things that may put you off a little bit is that as you increase the PEEP under those circumstances, they may suddenly start breathing faster, But now it's because it's easier for them to trigger the ventilator, and they will settle down after a while. They'll get into their new stride. So you can tune it up and down clinically without having to really measure pressure rate product. I think the other caveat I have with ventilating patients with obstructed airways is that if you're going to ventilate them going into their disease, and you can use quite high pressures on them, because they really have decreased chest wall compliance. You can use much higher pressures than you would in any ARDS case or anything like that. That's probably good to use pressure control mode of ventilation at that stage. When they're weaning and they're coming down and you're adding things to them, probably that's a good indication to go into some volume targeted or volume controlled mode where you're not overdoing it, because as they get better and they start to breathe more comfortably, you really can overinflate them under those circumstances.
Dr. Newth, this is such an important concept. I wonder if you could take us all through this again. In a child who's neuromuscularly relaxed, is paralyzed, and is on controlled mechanical ventilation, the problem with Autopeep and adding applied PEEP, take us through that again.
All right, well, let's think about it in terms of time constants and plotting tidal breaths out against time. As you well know, it takes us about 3 to 4 time constants to empty our lung from whatever volume that we put it into. If our time constants are relatively short, as they are in normal circumstance or ARDS, that's very easy to do at regular sorts of rates of ventilation. However, if you've got obstructed airways, your time constants become longer and longer, and it may be that you cannot get all of that tidal volume breath out, and that's when you start breath stacking, and FRC, or end expiratory lung volume, whichever term you want to use, starts to climb, and it will either go up and up until you unwisely cause some damage to the lung, or it will reset itself at a new equilibrium. So you set a new FRC, if you will. David Tuckson has measured this in adults. I'm not aware of any pediatric work, but what he showed is if you're under those conditions of neuromuscular blockade, fully ventilating somebody, if you went to the peak of a tidal breath on the ventilator and then did a long apneic pause, maybe 40, 45 seconds, and allowed them to breathe all the way out to FRC, or their end expiratory lung volume, if that volume was more than 20 mils per kilo, those were the patients that you're in danger of giving cardiac tamponade to, or air leak syndrome. I suspect the children may be a little more forgiving, but probably not much more forgiving. He went on to also show the effects on CVP and blood pressure and so on, and it's certainly pretty impressive if you increase PEEP under these circumstances or increase rate under these circumstances, just how much breath stacking and how much hemodynamic compromise you can create.
Kip, it's been a wonderful overview, but I'm sure my colleagues around the world are thinking the same thing that I am right now, which is what of the evidence out there now do you integrate into your practice to guide us as to what we should do now and where we're going in the future?
Well, this will be a very personal point of view, Jeff. I'll start by saying that, we rightly as pediatricians like the mantra that kids are not little adults. But in actual fact, because of the small numbers that we have in our various disease states and our ICUs and so on, medical care for children, at least in critical care, is often based on what works in adults. We seem to relate more to the adults than we do to the neonatologists in that sense. But I think one thing we do have to be careful about is that if we look at the evidence from adult-based studies, we tend to cherry pick what we like and reject what we don't like, perhaps without thinking about it too much. I like to think back to the ARDSNet protocol with a high tidal volume, low tidal volume study, which I think was a wonderful study, and they controlled both arms of the study with a protocol that they could all agree to and had a pretty good degree of compliance. And we have fastened particularly on one thing out of that, which is the 6 mils per kilo tidal volume. There's in fact quite a lot of differences between how ArtsNet adult practitioners ventilate their patients compared with how we ventilate ours. I can run through some of them very quickly, but we have in their protocols and in their tables, their ventilation tables, their oxygenation tables, they did things a little bit differently perhaps than we do. Oxygenation, straightforward, they use 10% changes in FiO2 for their grids. Is that what we do, or do we use 5% or some other combination? Their PEEP ranges went from 5 up to 18. You could go higher than that. Is that what we do with our patients in pediatrics? They had SpO2 ranges and arterial oxygen tension ranges for low, medium, and high. I think perfectly acceptable, but I'm not sure that they are acceptable to everybody who ventilates patients. They had pH ranges. They just had 4 boxes. My colleagues in the Collaborative Pediatric Critical Care Research Network suggested strongly that we should have more categories of pH at which to fine-tune ventilation, avoiding perhaps any acidosis whatsoever. I think we're rather influenced in that respect by our cardiac experience and probably our cardiac surgeons and the way they like things managed. But here we're dealing with lung disease, and I think we can be a bit more forgiving on the pH ranges. The adults are very strict about a predicted body weight. They have age and gender tables, and it doesn't matter if you're 120 kilos. If you're predicted to be 60 kilograms of body weight, then your tidal volumes are 6 times 60, not 6 times 120. We don't know what body weight we use. Our kids range all over the place. We have children who fail to thrive, children who are obese, children who have contractures. We can't measure their heights particularly well. It's important we start using the ulnar length, for example, by which you can predict height. We have good data now from 0 to 18 years, thanks to Jörg Hammer in Switzerland and Colin Robertson and his group in Melbourne, where we can predict heights if we wish to, and therefore calculate ideal body weights off our growth grids. And then we've talked about where tidal volume should be measured. If it is important, we should probably, up to some age, be measuring it on the proximal end of the endotracheal tube, not relying what's back in the ventilator on sick kids. And then, of course, modes of ventilation and pediatrics, at least in the Capcorn ICUs, pressure control was still the predominant mode of ventilation. Even in the Polive study, it was at least 50% of the mechanical ventilation. So we really aren't using a volume-targeted or a volume-controlled mode of ventilation. In the adults, you get what you get. We have, in pediatrics, also switched our practice. We tend to use far less arterial lines now than we did before, so we have many less arterial oxygen tensions to measure, except perhaps in the most sick children, hemodynamically unstable children, where we will use arterial lines, but we rely much more on the non-invasive measures of oxygenation. So, and these have the advantage of being continuous. So in fact, we can measure things like oxygen saturation, inspired oxygen fraction, O2 ratios continuously. And as long as the oxygen saturation is less than 98%, we can come up with numbers on the SF ratio which are pretty equivalent to the PF ratios. So a number for a PF ratio of adult ARDS of 300 is about 265 SF ratio. And the other end, say at 200 PF ratio, probably about 205 SF ratio. So within those sort of limits, we can tell where we are with oxygenation and create low, high, and medium gradients. Some of the, we talked about calculation of ideal body weight. Does it matter? Well, I think that clearly it matters that one doesn't overdo things, but in the face of bad lung disease, I think that pressure, if one limits pressure, and let the lung compliance decide what the correct tidal volume should be under those circumstances, that one can be equally as safe as trying to look at tidal volume per kilo, which we don't actually do very well. Again, from the Capcorn data, if you looked at the highest tidal volumes that were achieved on those children, it was 9.2 mils per kilo, certainly not 6 mils per kilo as we would have predicted. There was a range, but that was the median. But that was on actual body weight. If you looked at it with predicted body weight, then it went up to 10 mils per kilo, so quite a difference. One particular case, if you used the predicted body weight, the child would have been getting 47 mils per kilo per breath. That's a vital capacity breath, so that could do a bit of damage in the long term.
And again, these were children that had the diagnosis of ARDS.
They were specifically selected for having ARDS. There were no interventions, we just watched what people did.
But as you've noted, well beyond lung protective strategy as recommended certainly by the adult ARDS-NET trial.
Yes, I mean, I'm not trying to hold up the ARDS-NET protocols as being absolutely appropriate for children. They may well not be in some circumstances, but we cherry pick a little bit what we take out of them, and they do things differently, and we don't always do what we think we're doing. So going forward, one of the important issues, I think, is how can we, at least for the purposes of studies, so that we can really get some answers out of studies, how can we stop the various ways in which we all ventilate patients? How can we stop it being confounder? You know, we're all experts. We all know how to do it. You know, we're great. The problem is we all do it differently, so that it creates so much noise, it's hard to see a signal. And I think that's why the adult study was so good, is that they agreed on a protocol and could see a clear difference. I think if we could do that with some decision support tools, which for similar clinical situations in the sense of, you know, what's your oxygen saturation for this inspired oxygen, and how does that relate to your PEEP? If we could all make the same decision based on that combination, that would take oxygenation out of the equation of being a confounder, similar with ventilation studies.
Well, Kit, this has been a wonderful overview of many decades of experience in research and caring for children, and we appreciate your coming here and sharing your wisdom for your colleagues around the world.
Thank you very much for having me, Jeff. It's been a great pleasure.